Sorry, I'm moving over.
We are live, but that's all right. You get comfortable because I have to press another button over here which says go live, which isn't going to go live on me. I don't know why it never does. Oh, now it looks like it's doing something. Yes, we are doing that. We are live, and thank you for joining me again, Pauline Maki. It has actually been, I think it was just over a year, October a year ago that we last spoke, and much has changed in the world of menopause since then, and the brain and all of those sorts of areas. But before we get to that, let me give you an introduction. You are a PhD, a professor of psychiatry, psychology, obstetrics and gynaecology at the University of Illinois, Chicago, and I think I mentioned last time that looked a little bit like hoarding. You are award-winning. You are the past president of the North American Menopause Society, a trustee of the International Menopause Society currently. You've published more than 345 or so research papers, which is quite some going, I will say. And you are at the moment the co-lead of the longest running, I think, longitudinal study looking at women's brains. So there's probably very few people on this earth who know as much about what is going on in a human brain, especially a woman's brain, than you. So
yeah, I was studying menopause before it was cool, Fiona.
Yes, because it hasn't been cool for that long, really, has it? It's really only been coul for about the last, probably about the last 7 or 8 years.
Yes, I used to be relegated, to the back halls of academia, but, we need to know, women need to know.
Yes, they absolutely do. And at the moment, as you will have noticed over the landscape in the last year or so, there is a lot of what we would call FOMO, fear of missing out, fear of what's going to happen to us, and unfortunately a lot of misspeaking in various areas along the lines of, if you're not on HRT, your brain will eat itself or you will experience brain death, which
how have women survived over the millennia without hormone therapy? I don't mean to minimize its benefits for certain women, absolutely, and women have been under prescribed hormone therapy for its main indication, which is hot flashes. Absolutely, that is a huge disservice to women. But this perspective of hormone therapy as this miraculous anti-aging pill, it goes against the science.
Yes, the longevity argument seems to be coming back. We seem to be heading back to feminine forever at a very, very quick rate, which is interesting. Yes, but
of Robert Wilson.
Yeah, exactly. Yesterday another study came out that seemed to raise the ire of many, but not just raise the ire. Actually, the headline sparked an incredible amount of fear. In fact, I put up a little survey, and it came back showing that 47% of people were scared because of the headlines, which basically said that the changes in the brain were linked to changes that you would see in Alzheimer's, and women were understandably scared. 27% or so of them were confused, and 27% of them weren't worried, which is good. So at least somebody was worried. What when you saw that, what went through your head?
Yes, I'm so glad you did the poll, because I think this is the very nugget that we need to address, is what is the impact on women in their daily lives when we present information that is incorrect, especially alarming information. And, there was a study done, I think it was in the Lancet, where they actually studied what research studies get highlighted by the press. And it was negative information about women's health. That was it. So, there is this machine to pop headlines out, and it's oftentimes at the disservice of women. So when I have my cognitive lapses at menopause, like, 40 to 60% of other women, of course I am worried about Alzheimer's disease. Of course I am, right? It's like when our heart flutters, we worry about whether or not it's heart disease. And so we need to be very careful in weighing the quality of science when we tell women things like, your brain is shrinking at menopause, right? I mean, come on, because when I have that cognitive lapse, what am I going to think? Oh my goodness, it's because my brain is shrinking. So I, as you mentioned, co-lead this study with Susan Buchheimer from UCLA in the Adult Aging Brain Connectome Project, which is a branch of this huge project in the United States called the Human Connectome Project. We're in our 8th year, Fiona.
Wow.
8th year of collecting longitudinal data, because doing this research on what happens to the female brain takes a really long time, because to do it right, you have to follow women from premenopause to perimenopause to postmenopause and see what changes as their ovaries age and disentangle that from age. So it's a hard science. It's a long science. People want quick answers. And so they look to databases that really weren't designed to answer the question. And that's how we end up with misleading, anxiety-provoking, fear-mongering kinds of headlines, and the media picks up on it.
But the irony was that the study didn't even mention dementia or Alzheimer's.
That's right. That's right.
It was really comments afterwards when they were saying, well, perhaps this could indicate these changes that, you know, that there are, as you have talked about before, and we talked about in my beautiful product placement there.
It's a great book. Buy the book.
And we talked about this, the vulnerable brain. But
yes.
let me just get through some of these other bits before we get to the vulnerable brain, because some of the things that they did look, there were lots of things in there that they said were basically HRT, or MHT as the rest of the world calls it, doesn't seem to make any difference to these changes in grey matter volume. And we already knew that. So what does it tell us?
Yeah, so here's the challenge, Fiona. There is this temptation to believe parts of research studies that align with our viewpoints, and to maybe be skeptical about the parts of the research studies that don't align with them. I have to take the standpoint that if I'm going to be as critical about a study, I need to be as critical about it for everything, meaning I can't select. And I want to say that this is important, because in the UK, we hear people saying, oh, the WHI was terrible. And then they take the WHI data on estrogen lowering risk of breast cancer, and then they tell women that estrogen lowers the risk of breast cancer. So this is, I think, intellectually dishonest and scientifically misguided. So, you know, the UK Biobank study is a treasure trove. It is such an important study for brain health. And we who do neuroimaging research are so fortunate to have this treasure. But it's not a treasure for menopause research, because you need to ask questions about menopause that allow you to answer questions about menopause. And like a lot of other research studies, they asked one question, which is, you know, have you had your menstrual period in the last 12 months? And like a lot of research studies, they asked, have you ever used hormone therapy? So, you know, that's an observational study, and we know the challenges of making conclusions from observational studies. There is some benefit to the size of the UK Biobank when it comes to observational studies. There's no doubt about it. But we have to be cautious when women are recollecting their use of hormone therapy. How accurate was it? How long did they use it? Did they use it for a month? Did they use, you know, all of those things? And so,
And what types as well.
And what types, right, exactly, what types, because we do think that, especially for the brain, the types that were used very commonly in the 1990s, conjugated equine estrogen and medroxyprogesterone acetate, which are fancy words for Prempro, you know, that was toxic to the brain. The medroxyprogesterone acetate was toxic in randomized trials. So that can make a difference. So we need to be appropriately cautious about using observational data generally to draw conclusions. And yes, it was, the data did align with what clinical trials have said about hormone therapy and cognition. And that's important and it replicates, but it isn't the best quality science, right? It's an observational study.
Yeah. You mentioned in there something that is very interesting, the dissecting out of all of this age-related changes and menopause-related changes. Now, I went down a little rabbit hole this morning because I just can't help myself. And I thought, hold on a second, what's happening then in men's brains? And it does seem that around between 40 and 50, and then between 60 and 70 again, they have quite rapid changes in the amount of grey matter that they've got. So how does that compare to women?
Yes.
And is there an argument to be made then if we're hanging on to these things for a little bit later, then perhaps there is an estrogen effect that helps. But is it when it starts to go down? Is it age or is it not age? What's going? How do we draw out that age from the estrogen?
Yeah, it's really tricky scientifically to do that. The first thing you need to do is you need to truncate your study so that you're only looking, say, at women between the ages of 40 and 60. I see studies that say that they're studying menopause stage and the age range goes up to 75. And I'm like, well, that's completely confounded, meaning you're not going to find a 70-year-old who's premenopausal. So any effect that you see in the postmenopausal group is contaminated by this bias toward that group really representing old age rather than representing postmenopause. So the first thing you need to do is to kind of truncate your age range. And then you adjust for age. And ideally, this is why we want the longitudinal studies, because we want to be able to track a woman as she's aging chronologically versus as she's aging reproductively. And it's very hard to disentangle. I can tell you how we do it in the AABC project. So my graduate student, Katrina Wugalter, presented at the Menopause Society, kind of the first in show data from what we have been waiting for, which is a sufficiently large sample of pre, peri, and postmenopausal women. I want to say at the outset that we presented these are not peer reviewed, and your audience should be skeptical of data that has not yet been peer reviewed. So we are submitting this for publication, but like other scientists, we presented at a conference first. So Katrina presented data that had very large numbers of women, in the hundreds and hundreds of women, who differed in whether they were pre, peri, post. We do not yet have enough longitudinal transitions to draw conclusions about longitudinal change. We're awaiting those. We're just beginning to get them. We're excited, but this is also a caveat. It is not longitudinal. And what we found is that in this very carefully characterized, so we use straw plus 10 for your audience, that is the gold standard approach for determining whether or not somebody is pre, peri, or postmenopause. And then we went through every single case and we said, is she on hormones? Did she have an endometrial ablation? Did she have a hysterectomy? Does she have a history of PCOS? Is there any other factor that could explain her menopause stage? Because as you know, a number of factors impact the regularity of our menstrual cycles, right? So we cleaned the data and we had gorgeous imaging data thanks to my colleagues at the Human Connectome Project, who are really world experts in this. And we found, wow, significant effects of age between the ages of 40 and 60 in both men and women. We didn't present the men, I don't think, at the Menopause Society, but we showed the same loss. So yeah, when you're our age, we are losing our brain volume, unfortunately. And it was in many, many areas. I think we had like 120 different areas that were getting smaller. And this is normal aging. And then we asked the question, what about menopause stage? Nothing. There wasn't a signal. There wasn't a trend. There wasn't any signal related to whether a woman was pre, peri, or postmenopausal. Why is this important, Fiona? Because if my brain changes are tracked with menopause, then there's one solution. If it tracks with aging, then there's a different approach, right? Because we know how to modify age-related changes in the brain. And I don't know if hormone therapy modifies the female brain. I know everybody wants to think that. I think our work suggests that it certainly does for women who have symptoms But otherwise, the randomized trials say no. So yes, we see these age-related changes in both sexes. And in the women, we see the age-related change without the menopause stage-related change.
Yeah, no, that's really interesting, isn't it? Because that's I think you should publish it with the men's data alongside, because I think that makes it just do what I say. I know absolutely nothing, but I think it just shows that that it is, because otherwise, when I was looking at it earlier, and I was thinking, well, if this is the case, then how come we aren't all screaming all men are going to get Alzheimer's because of these changes? And some of them are in the same areas, as you say, that they were related to later, to going on to develop Alzheimer's. So
can I say something about that, Fiona?
Yep.
So I think it's tempting for us to say that if it shows up in men and it shows up in women, then they're kind of experiencing the same thing. But it can be the case that the brain loss in women is more due to, say, sleep problems that we all experience, not all of us, but many of us experience at menopause, whereas the men's loss of brain volume is due to something else. And, animal studies have teased out things like the female Alzheimer's disease phenotype, the way that we are vulnerable to Alzheimer's disease, has much more dependence on immune factors compared to a male's. So, sex differences isn't always hormonal differences, is the point. And men and women can show similar patterns, but the causes of those patterns can be different.
All right. Well, let's have a little look at those then. What makes it? Because we did discuss this at length in the book, the vulnerable brain.
Yes.
What is it that makes my brain more vulnerable than somebody else's, but hopefully not?
Yes. And this is really important. I just got back from Davos and I presented in a panel where the questions were about the need to take a lifespan approach to the brain. And I think we need to think about the brain we bring into menopause, and we need to think about the brain we bring out of menopause, right? So what are the factors that make one person's brain more vulnerable than another? And I'd like to focus on the female brain because after all, that's my life's mission. So one of the factors that can make the female brain more vulnerable, even outside of menopause, is our higher rates of depressive and anxiety disorders. And those conditions, affect almost twice as many women than men. They are tied to our reproductive systems. So the female brain doesn't like changes in estrogen and progesterone. And that's when we're vulnerable to mood disorders. So one of the predisposing factors is our vulnerability to mood problems. Other factors are related to our early life. So believe it or not, our risk for Alzheimer's disease is determined beginning in utero. Maternal stress, malnutrition, exposure to toxins, all of those affect what's called epigenetics, what genes get expressed later in life. And so, we need policies that support women when they're pregnant, policies about the environment, and treatments for mental health disorders in moms. And that has trickle-down effects into Alzheimer's disease. Then we have early life childhood adversity, trauma, stress. We have these childhood events, adverse childhood events, and the more of those we have, the more vulnerable our brains are. So early lifestyle. Nutrition is really important. There's a book by Annie Fent, and she had done the randomized trial looks at how do we eat to protect our brain. We want to do things like consider how much alcohol we bring in. Women shouldn't have more than one drink a day, right? I know, right? It's challenging, especially when we lead stressful lives, and it's right there. We have to think about how much physical activity we get. I know it's so boring to talk about exercise in the brain, big yawn, right? But 150 minutes of moderate exercise really does affect the brain, and you can see in randomized trials growth of certain brain areas, which is really great to see when people are randomized to exercise. It should be aerobic exercise, right? That's really important. We need to avoid things that put our brain at risk for traumatic brain injuries, because when we have a traumatic brain injury, there's damage to the brain, and the pathology of Alzheimer's disease will be more apparent, unfortunately. So skiing and other things, we have to be very cautious about the risks that we take. We have to stop smoking if we smoke. That's one of the factors. And then what you're doing right now, Fiona, you're educating women, you're having women learn new material, learning challenging material, maybe like listening to me talk about the brain is very good for the brain, because we want to continue to build brain muscle. The more synapses, the larger our brains are, the more our brains can tolerate the pathology of Alzheimer's disease when it emerges. And then finally, I'd like to talk about the importance of early life education. Your listeners include a lot of moms. And, early life education and your achievement educationally when you're little really does predict your risk for Alzheimer's disease years later. There's this famous study called the Nun Study. I don't know if you've heard about it. They had narratives that these nuns wrote when they were between the ages of 19 and 31. And the more complex the ideas in those narratives, the more resilient those women were to Alzheimer's disease later in life. So building a better brain is really important. One sister, Sister Mathia, lived to be 104.
Wow.
She had a deep idea density. Her thoughts were very complex. When she died, her brain was full of Alzheimer's disease pathology.
Really? But yet she still managed to keep going.
She didn't express it at all. So, keeping our brains active, building a lot of brain power is one of the most important things we can do.
Yeah. Although, devil's advocate, we look at some very, very smart people who've had Alzheimer's.
Absolutely.
So there must be something then that is beyond just being smart that gives you sort of protection, which then leads me to some of the other things around menopause that may have an influence that we discussed last time, which were snoring, vasomotor symptoms, poorly controlled blood pressure, all of those sorts of things. How do they impact on our risk?
Yeah, so our work, and when I say our, I mean my work with my good colleague and friend Rebecca Thurston, who people might know as probably the world's expert on hot flashes and the brain. Hot flashes in the cardiovascular system. So she has published, for example, associations between hot flashes and your risk for a heart attack later in life, and even your lipids and the amount of plaque you have in your heart. All of that is tied to menopause and your hot flashes at that time. The work that she and I have done, and work that I've done with others as well, suggests that really we need to shift our focus from the idea that we treat estrogen loss as a cause to we treat the consequences of estrogen loss as the cause. In other words, we treat the hot flashes, we treat the sleep disruption, we treat the mood disruption, we treat changes in cardiovascular health that can occur at menopause, changes in body weight and metabolism that can happen at menopause. And that's the key to maintaining our brains, because after all, 27% of women sail through menopause without any problem. We published a study showing that only 20% of women show significant kind of cognitive issues during the menopause transition, and others even get better during the menopause transition. So my menopause is not your menopause, and symptoms have a lot to do with it.
Yeah, it was interesting. There was a Harvard study a little while back that came out. It was only small. It was 64 high-achieving women or whatever it was. And I think, and they were showing that basically how they managed to get through it and did very, very well was because exactly what they took charge of it in a way, and they said, okay, this is the information I need to know to get me through this. This is what I need to do. And then they became mentors in their workplaces. And that was really
wonderful.
Nice. Yeah.
That's wonderful. Yeah, it's so important that we treat these symptoms because there's so much unnecessary suffering.
Yeah.
So unnecessary suffering.
Exactly. And the other thing too was another one that came out that was looking at executive function in older people, not just men, but in I mean not just women, but men as well. And it was showing that okay, we may not be as fast at picking various sorts of things up, and we rely on different parts of our memory, but our executive function was at its peak. So it's not that we can't perform anymore. We just sort of perform slightly differently.
Our brain is very plastic. Our brain adapts, our brain compensates. There's a researcher in California named Emily Jacobs, who many years ago published one of my absolute favorite studies, brain imaging studies in the field of menopause. And what she showed is that memory systems in the brain appear to adapt to decreasing levels of estrogen by recruiting other areas of the brain on the opposite side of the brain. Yeah. And then women perform just fine. This is what we do when we're sleep deprived, when we're changing time zones. Our brains adapt to these changes. And, obviously 80% of women don't develop dementia, even though they go through menopause. So really, is menopause causal? It's
and that I think is one of the most say, yes, 100% of us go through it, but not all of us develop heart disease, dementia, osteoporosis. So it is really, as you say, finding out who those vulnerable people are, so we can make sure that they actually get what they need, isn't it?
Yes.
The other thing that I found interesting about this study from yesterday was that it said, because you'd mentioned before anxiety and depression, and it was showing that in postmenopause, those persisted, which is interesting because we're always getting told, once you're through on the other side, you'll be fine. But it turns out that perhaps it may not be that rosy on the other side when it comes to anxiety and depression. They seem to persist.
Yeah. So let's talk about this interpretation. So the challenge is that how do we know that has anything to do with menopause? I mean, what they found is that, the levels of symptoms were higher in women who said they hadn't had a menstrual period in the last 12 months compared to other women. What does that due to? Is it due to menopause? Is it due to accumulating caregiver burden? Is it due to all of the stressors of women managing sandwich generations? What contributes to it? I think there is this idea that if you define postmenopausal women and find a difference between postmenopausal women and premenopausal women, you want to attribute the difference to menopause. The better studies on this, I think, come from the SWAN, where you have thousands of women followed prospectively, and you measure mental health through the gold standard clinical diagnostic interview. You do the really hard work. Another good study on this is the Pan-Ovarian Aging Study. And indeed, they show that there is an inflection point where around the final menstrual period, women do have higher levels of depressive symptoms and they have higher levels of anxiety symptoms. Those symptoms, however, they trail off within, say, 5 to 6 years of the final menstrual period, except if you're a woman who entered menopause with a history of a depressive disorder. And then the rates continue to increase. So this is really important to know because many of us have had major depressive disorder, and we need to consider our menopause experience as being one where we're disproportionately vulnerable, right, to having sustained mood problems. And then how do we treat that? And I don't think necessarily that it is the estrogen loss that we need to treat, because randomized trials in postmenopausal women show no benefit of estrogen in the postmenopause. Conversely, it's very beneficial in the perimenopause for mood. Small trials, but reliable findings. And so, we need to personalize the care of women and tailor our treatments thinking beyond the loss of estrogen and more to, continued sleep problems. Not for weeks, not for months, but for years. Well, what happens after 20 years of sleep deprivation? It's not surprising that your mood is not great. What happens if you continue to have untreated hot flashes? That's where I think we need to shift our focus.
Yeah, yeah, yeah. The other thing that you mentioned before about things that are good for preventing brain deterioration and stuff, and, the exercise and whatever. There was an interesting study or an interesting article on Medscape yesterday that came out talking about hearing aids. And we know that that's one of the 14 things on the list to make sure that you've got your hearing under control. And basically what they were saying was they didn't see an awful lot of difference in people's cognition when they were using their hearing aids, but there was what they called a striking 33% or so association with lower risk of going on to develop Alzheimer's disease. That's fascinating, isn't it?
It's fascinating. And I love this focus on hearing aids, and because it's actionable, right? There's something we can do about it, and it's encouraging for people. And I think it empowers people with evidence. And you're right, we have recognized for some time the importance of making sure that our hearing is intact, because when our hearing isn't intact, what are we losing out on? Social engagement. And social engagement is so critical for our thinking and for our cognitive resilience, and even for our heart and our overall mortality, right? And so hearing aids are really important for that. And the other thing that happens when we can't hear well is we spend a lot of time in our heads.
Yeah. Yep, exactly.
That's not a good place to be.
I mean, you can't even hear the news. I mean, because I am what I would call a self-proclaimed antisocial cow.
I've never seen you that way, Fiona.
Generally, I don't like large crowds. I don't like,
Oh, I see. Yes.
I'm a sort of, one-on-one type person. I don't really like big things, but it does. I mean, even I would imagine that if you can't hear well, you're not even going to be engaging, socially with the news, what's happening in the world. You're
That's
just
right.
going to become much more and more restricted to your right, sort of just coming inside your own head, which some places that sometimes might not be a fun place to be.
Right. And you think about what you and I are doing right now. We're having a conversation, right? So I'm listening to you. I'm hearing what you're saying. I'm encoding it into my memory. I'm going back in my memory stores to try to process what you're saying, link it to other information, and then think strategically about how to respond optimally to you, and then converse, right? That's a lot of cognitive activity. That's what we mean when we're building cognitive reserve, right? And so, yes, of course, when we can't engage in those conversations, we don't have the same amount of brain activity, and we're not building the same brain resilience.
Yeah, it's a fascinating area. So where do we go from here? So you're sitting there with you're co-leading this research. What's coming up next for you? What are we?
Yes. So we're excited because after 8 years, we're finally beginning to see some longitudinal transitions between women who are going from pre to peri and peri to post. I still think that scientifically it's not enough. So we're excited. We'll get some new data. I think the quality of our cross-sectional data is going to be exceptionally strong, and the sample sizes are going to be larger, and we will have multiple scans of women within each phase. So that's going to be good too. And I work with just such a great group of individuals, just a brilliant set of individuals there. And so we're excited about writing up about 4 papers from that data set. And then with the lovely and amazing Rebecca Thurston, we have received money from the National Institutes of Health. And we're starting a similar study with a much more powerful brain imaging scanner, 7 Tesla. It allows us to see exquisitely small details in the brain, which is what you want if you want to measure the effects of menopause. We're not dementing. We're not dementing, so we're not going to see these big changes. They're small, so your equipment has to be sensitive. So we're doing that, and because Rebecca is this, expert in cardiovascular disease and menopause, we're also having cardiovascular imaging. So we'll be able to link the brain and the heart, which is something we do in our studies of postmenopausal women. The Chicago. Sorry, I'm going to switch here.
We've just got eternal.
Sorry about that. It's good to have sunshine. We in Chicago really love it. So we have that study starting as well. And then Emily Jacobs in California is starting a very large neuroimaging study. It will take some time to acquire all the data in this multi-site study in California. But the good news is that we're getting more data sets that will be longitudinal and will be able to answer these questions. So women should rest assured that people are studying this. But again, unfortunately, we need to be somewhat patient because it takes a long time to do the studies right.
Yeah, exactly. That's really interesting, actually, because I mean, with INOCA, ANOCA, and MENOCA, all those like microvascular changes that happen in the heart around.
Exactly. Yeah.
Yeah. So you'll be looking for similarities, and if they're happening in the heart, are they happening in the brain?
Exactly. Yep, that's it. And how much of menopause-related brain changes are related to cardiovascular disease? You know, we find that hot flashes are associated with small stroke-like lesions in the brain, and this puts, you know, very much a cerebrovascular slant to what we're seeing, right? And so we need to understand, is that relationship causal? What's happening here? Are hot flashes working on the brain independently? Are they working through the cerebrovascular, working through general heart health? Or is it something more targeted, something periodic? We need to know all of these things.
Wonderful. Can you throw in a bit of vulva while you're there as well?
Yeah, I wish we could. I think sexual health is so grossly understudied in the field of menopause research, vulvar health being really important and vulvar pain being really important. And, you know, let's not, ignore the effect of pain on the brain.
Yeah.
Right?
Exactly.
I mean, your genital pain, the pain that women express here every day, day after day for weeks and months and years, that pain has significant effects on the brain. And so, I mean, you raise that kind of, I think, cheekily, if you will, but I think, you know, we do need to understand pain and how it affects our brain health.
It just seems to be very, very logical to me that if there are microvascular changes happening in other places and erectile dysfunction is part of a microvascular sort of issue, then it's going to be related when it comes to surely.
Absolutely. Yeah. And what are the solutions? Are there global solutions for that? Yeah.
Yeah. There you go. So that's my 2 cents worth of the day. Brilliant.
I'll take it.
And I'm very, very glad that you've got some funding in this current environment, which is not an easy one to operate in anywhere in the world, but at the moment, particularly where you are.
Yes. Yeah. And, you know, Fiona, it's exciting to see the increase in menopause research and the interest in it. There's a lot of people trying to do it. I think there's a need for better training in how you do a menopause study. How do you define menopause? How do you define menopause stage? What is straw plus 10? So, you know, we need to make sure that as we start answering the questions, we're using the best research study designs and designing our studies from the beginning to answer the questions that women deserve the answers to.
Yeah, absolutely. Any take-home messages for clinicians or women?
I think that, we talked about this study that was released on women's brains shrinking at menopause. I just want to reassure women that when you do the optimal study design, we're not seeing that. That the headlines came from a study that was not designed, and I think, frankly, can't really answer the question. So don't think when you're having cognitive lapses, and we do, they're a normal part of menopause. Don't think that you're dementing. What's happening is your brain is adjusting to changes in sex steroid hormones. It's rewiring itself. And your symptoms, if you don't treat them, are impacting your brain health. So really consider getting effective treatments for your hot flashes. The use of ineffective treatments for your hot flashes will do no good for your brain. So the use of a supplement will not do your brain well. You need to use evidence-based treatments for those symptoms in order to reap the benefits. And I would just say, you know, if you're skeptical of hormonal or non-hormonal therapies, non-hormonal meaning the new kind of FDA-approved medications, you don't have to commit to a lifetime of their use, but maybe you want to give it a try.
Yeah, give it a go. Fezolinetant and
Give it a go. Yeah.
elinzanetant. Yes, I'm very impressed.
Yes, fezolinetant and elinzanetant.
Yeah.
There's a brain teaser. That's good for your brain.
Oh, it certainly is. Absolutely. Brilliant. All right, my lovely. I will let you go. Thank you so much for that and all of that reassurance. And hopefully we shall speak again in the future.
Thank you for everything you do, Fiona. And everyone, buy that book. You see that book in the background? Buy that book. It is so well researched. I highly recommend it.
Oh, thank you, Possum. And also the Menopause Research and Education Fund. Hopefully we will we've got a very exciting thing coming up, which I'll tell you about later, that will hopefully actually start producing enough money to actually help fund research as well, as opposed to just talking about it.
Yay.
Excellent. All right. I'll speak to you soon.
Yeah, take good care, Fiona.
You too.